SBU is the Spina Bifida Association's new viral education program. Our goal is to bring the world's best care providers and resources directly into your home. SBU is the only free webinar series dedicated solely to the educational, employment, social, self-advocacy, and health needs of people with spina bifida. We hope that you will enjoy today's presentation, Aging and Adult Issues with Spina Bifida, and that you take time to complete the evaluation at the close of the presentation.
I think we're going to go ahead and get started. I have that it's just about 4 after 4, and I know everybody's been here for a long time. It's kind of the last talk of the day. I'll go ahead and introduce myself. Can everybody hear me? I'm Kirsten Sovis. I'm a peds rehab physician. I also trained in developmental pediatrics, and then for about 10 years, did geriatrics. I am talking today on aging and adult issues in spina bifida. Dr. Bry asked if I would cover this topic. I hope I address what you wanted. I had a first talk done, and then he asked me if I would talk a little more on the orthopedics, physical exercise and disabilities, and some other topics, so I flipped my talk. So I'm going to talk on a diverse number of issues, and then we'll have questions and answers at the end, okay? I do work at Riley Children's in Indianapolis, and I've been kind of throughout the U.S. in the past. I trained at Hopkins, and then I went to Little Rock, back up to North Dakota, where I consider my home, and then now I'm down in Riley in Indianapolis. So that's kind of my background. I was a physical therapist as my first training. I practiced for a couple of years and then went back to med school. So we're going to talk about aging and adult issues with spina bifida, and then, like I said, we'll have some questions and answers at the end. I'm very laid back, so if you have questions, like I said, we're going to leave some time for that, okay? Aging is just a natural process over a lifespan in which one changes in knowledge, muscle strength, and other physical and psychological changes. And I put this picture here because we can't all stay as infants. The child in the center is an infant. That's my youngest. She's adopted. But if you look here, we have one doll with braids. That doll is actually 12. The other doll is 20. And the one in the middle is my baby doll, and she's quite a bit older. So we can't stay as little infants. We have to mature as we get older in our knowledge. The child is protected by the parent, and the parent gives knowledge to the child. As the child gets older, they will gain in psychological understanding of how the world comes. When we're a child, we have mystical thinking, and we believe in the fairy tales and things our parents give us. As we get older, we can still have fairy tales and beliefs, but we also have an understanding of the concept of life. Muscle strength is something we develop. We peak in our younger 20s, and then we want to try to maintain that as we get older as much as we can. And then again, we have physical and other psychological changes. We first start off in a child form, we go through puberty, and then we become adults. And so all those changes as we age. Age is a concept. In the U.S., adulthood legally begins at the age of 18. In other countries, it's slightly different. But old age is considered to begin when we retire. Infancy is generally birth to 11 months. Childhood is 1 to 12. Adolescence is 13 to 19. Tell that to my teenagers. Early adulthood is 20 to 39. Middle adulthood is 40 to 59. I'm still in that middle adulthood. Isn't that great? And late adulthood is 60. So we have these age spans at which we're in, but to me it's whatever age you want. You can feel as young as you want or as old as you want. It's what you consider youth. But we do have these periods to which concept is what we talk about. Successful aging. These were definitions that I found. Successful aging is a low probability of disease or disability. My feeling is we should take the word disability out and say impairment, because everybody generally may or may not have a disability, but it's really not the disability we're talking about. We're talking about the impairment. Impairment is what your disability interferes with your life successful. Are you disabled? You could be. But does that disability impair you for your function and daily activity? Are you impaired in getting to work? Are you impaired in your life satisfaction, in your ability to do recreations? Are you impaired in your ability to get dressed? So again, low probability of disease, or I think it should say impairment, high cognitive and physical functional capacity. So do you have the cognitive ability to do what you want? Again, high cognitive is again a perception. I know a lot of individuals who may have a cognitive ability of 50 IQ to 70, and they do just fine. So again, it's your perception, but generally the definition is high cognitive and physical functional capacity, and then active engagement in life. So this is what, again, the definition of successful aging. I think we can modify it, and that's what the bottom line is going to say. A greater number of people self-report successful aging than those who strictly meet the criteria. I can think of a couple of young adults that I work with who would say they're doing very well, okay? Because their perception is life is fine. They live in an adaptive apartment. They have their attendance, and again, they're doing fine. They're in their 30s. But again, they report that life is good because their quality of life is fine. So again, it depends on your perspective. Dimensions of successful aging. Again, this is where I looked at different articles. And again, the dimensions that are defined, and I think this is, again, a perspective, a feeling, but minimal increase in physical disability over a lifespan. I think, again, if you have minimal increase in your impairment over a lifetime, you're doing well. Good subjective health assessment. Again, are you staying healthy? Are you having little impact in your increased health impairment? Do you have good mental health? If your mental health is good, you're generally feeling good. Is there objective social support? Do you have a good social system that's supporting you? And then self-rated life satisfaction in 8 domains, namely marriage, income-related work. Are you able to work and support yourself? Do you have children or friendship and social contacts? Do you have hobbies that add to your life? Are you doing something that adds positive experience? Do you have community service activities? Those who do community service tend to have a more positive outlook on life. And then is there religion or recreation and support? Those who participate in recreation and support have a higher life quality. Now, there's our leading causes of death that have been ranked, and we're going to talk about a few of these as they impact on those with spina bifida, but these are some of the leading causes, and you'll notice that I jumped from 9 to 13 because I think 13 is essential for us today. But heart disease, neoplasm, cerebrovascular disease, and we can go through the name, but I'm going to jump down to diabetes, kidney impairment, and then essential hypertension. So we're going to get to those near the end and how they impact individuals with spina bifida. So what are we going to talk about over the next hour? Well, we're going to talk about how mobility may impair your sense of aging and how that will affect your aging over time, joint protection, how it is necessary or important to try to save your joints from undue injury. Osteoporosis is an important aspect to look at, then exercise and fitness and health prevention. I think we can all say that ambulation and mobility is important. Mobility is a key component for life success. If we cannot get around in our environment and in our community, then it is not good to our quality of life. And mobility can be defined in a couple of ways. I think when I work with parents, their biggest thing is, when you talk about spina bifida, is will my child walk? And I always say, well, how important is walking to you? Because in society we think that walking is the most important thing, but walking really isn't the key to everything. It's can you get around in your society. So whether you walk or you use a wheelchair or you use a walker or you use a scooter, it's key to your quality of life. If you can't get out of your home and you can't get to where you're going, then you're impaired. And so we have to preserve mobility throughout a lifetime. And so we have to talk about that 5-year plan. In 5 years, what's your mobility going to be? Can you maintain your mobility? 5 years from then, can you maintain your mobility? And how do you want to see your mobility? Because mobility is key to your independence. If you don't have mobility, then you're not independent. You're dependent as you age on somebody else. If you don't have mobility in your home, then you're dependent on somebody for your daily living. And then you become dependent and you become that childlike figure as an adult. If you don't have mobility, then you're not employable. And it has to be good mobility because you have to be able to get around in your community. If you're not reliable in getting around your community, then you're not employable. And then you have to have good mobility so you can get around in your community. If you don't get around functionally in your community because the bus only runs at certain times or the taxi system only runs at certain times, or if you live in a rural area like I did and there's nothing in the evening, then you're limited. Grand Forks, North Dakota was a great community and I really liked it, but after 7 o'clock, how are you going to the dance? Or if you want to go to the mall, it got really hard because the public transportation just wasn't there. So a couple of my friends, if I wanted to go with them, we had to take her van and then pick up the other girls, and then we would go to the mall or we'd go to the wedding that was there. But we always had to figure out how Heather was going and how the other young lady was going because, again, they both had power chairs and the public transportation wasn't available after 7. So, again, it becomes a problem. And then recreation and leisure activities are very important to key in life. Ambulation and mobility is also very important. And when I talk to teenagers about ambulation and mobility and to parents, we really want to talk about long-term mobility because I think, again, a lot of parents focus during the teen years and they're really gung-ho on keeping kids ambulating, but they're not thinking about what they're doing to the shoulders or what they're doing to the hips or what they're doing to the knees because we've got to look over a lifespan. We know that back in the 60s and 70s, there was limited lifespan, but we now know that people with disabilities are going to be around into their late 60s and 70s, and so we've got to preserve joints. And so we know that approximately 92%, or we can say almost all individuals with S1 and below, that means limited involvement of the feet, are going to ambulate as adults. We know that about a third of individuals with L5-S1, that means you have strength down to about your knee, you're going to ambulate as adults also, but some of them are going to use wheelchair and a walker, and less than 5% of those with L2 or above. That means you have very little sensation and function at the hips are going to ambulate. So again, we can talk to parents of teenagers about what the prediction is for adults of who's going to ambulate. And if I said that too fast, what I'm saying is if you have function all the way down to your feet, you're probably going to ambulate as an adult. If you have function down to your knees, about a third of individuals with spina bifida are going to walk as adults. And if you have only strength at your hips, most are not going to walk. And so again, when we're talking to teenagers and young adults, we're going to talk about how we can save your joints so that you can walk as an adult, or maybe we should just focus on other things as a teenager so we can save your time and save your joints. Factors that negatively impact your ambulation as adolescents and young adults are the following. If you have a tethered cord, you may lose your neurologic function. So what do I talk to parents? When I'm seeing the babies when they come into clinic, I always tell parents that I've got a foot fetish. I said, I'm looking at your baby's feet. And I'm the doc that's going to look at your baby's feet every time they come in. And they go, huh? She's looking at feet. And I say, I want to know what your baby's feet can do. Can your babies wiggle their toes? Can they turn their feet in? Can they turn their feet out? Can they dorsiflex their feet up, put their feet down? And the parents go, wow, she's really interested. I said, undress that baby. And then when they come back for each year follow-up, actually in the babies we see them every 3 months, but when they get a little older we're seeing them every 6 months, and then we're seeing them every year. I look at everybody's feet because I want to know what the feet are doing. If you get a tethered cord and you have innervation all the way down your feet. You have everything to lose. So I'm always looking at feet. If I notice as a child you don't have function all the way to your feet, but you got function at your knees, I'm telling them I'm looking at your cute knees. And so every time you come to clinic, I'm looking at your function. Because I want to make sure that if you get a tethered cord, are you losing anything? Because if you're a walker, you got everything to lose, and you don't want to lose it. So we're always looking at strength. Spasticity can interfere with your ability to ambulate, and again, if you get contractures. So we're always, as rehab doctors, we're always looking at everything you got, because if you get a tethered cord and you lose something, that's a shame. And we want to make sure you don't lose anything as you're getting older. The other things that can affect your ambulation and your mobility is motivation. Now, is that a problem? Not really, because not everybody has the same desires in life. But we do talk to parents that we want to make sure that those who are very motivated stay walkers. Those who aren't motivated, we want to make sure that the parents understand, well, what might make this teenager click? Once you get to a young adulthood, we have to decide what is it that you want in life, so that we're not hounding somebody to keep walking that is just not their goal. The other thing that will lose your ability to ambulate is something called obesity, and it creeps up on all of us. Obesity is a silent robber of your mobility. If you get too heavy, you're not going to be able to continue to walk, because if you're too heavy, that's too much muscle mass to carry around. And so we all have to watch what we're eating, and we talk about that as young children, teenagers, and then young adult. You have to balance that, and there's a balance between what you're eating and what you weigh. And we do have to look at body physique, because there are some kids who have a very short torso, and they're going to look heavy, but they're really not overweight. But we do have to balance what we eat. And in America, we have a lot of food available to us, and so it's very easy for us to become overweight. But obesity is a silent robber of your mobility. And then time limitations. If it takes you a long time to go from point A to point B, then there's no reason to take that long if you can do it in a wheelchair or you can do it in a power chair. So we have to talk to parents and young adults. If you're going to college and it took you an hour to get from one side of the campus to the other, then you can't concentrate on that class you're taking, and you need a power chair or you need a wheelchair. If it's taking that young teenager, an hour to get from one side of the high school campus to another, I've got a few large campuses in Indianapolis, then it's no good, and they need a manual chair or power chair. But every time somebody asks me as a teenager or young adult for a power chair, I say, this is what you're exercising, and what are you going to do the other 3 times of the week when you want to exercise? And we're going to get that to the end. You got to do something else called aerobic exercise, because if you don't, you're going to put on some weight. So we got to talk about that later. So again, on mobility and the level of lesion, young adults, relatively good walkers, are more likely to remain ambulatory. The more restricted ones are going to tend to be wheelchair users. But the key is that they should try to stay household ambulators as much as possible. And why is that? Because unfortunately, as much as we all want to think about it, not everything is accessible. And I think that most of you are finding that out when you're staying at the nice hotel across the street. Not everything is accessible, and if you can be a household ambulator, you can get to more things. With advancing age, though, we do know that there's an increased shift to wheelchair users because of acquired pain, and it's more energy efficient. So again, we have to keep that in mind. As people get older, there may be a shift, as it may be more energy efficient to go to a wheelchair, and pain may creep up on people. Now, what about joint protection? We don't have a lot of studies at this point on individuals with spina bifida for joint protection. We have more to look in the spinal cord injury. And again, why is that? That's just because the adult population with spina bifida is only coming of age, because I kind of alluded before, the survival rate for individuals with spina bifida is just becoming to be adults. In the 60s and 70s, individuals with spina bifida were not surviving into adulthood because of difficulties with the disability. But now we have adults becoming of age, and so we should have more studies coming. But in the spinal cord injury population, we know that the prevalence of shoulder pain is anywhere from 31 to 37% when you look at the studies, and wrist pain is 49 to 73%. That's problematic if you want to maintain an active life, because if you're having shoulder pain, it's going to interfere, as most of you know, with your dressing, your ADLs, and your general recreational activities and other activities that you're doing. And wrist pain is also, if you're using a lost-strand crutch, or if you're using a walker, or you're propelling your chair, anything that you're doing, it's going to really impact on your mobility and your quality of life. And again, if you have to become dependent on your loved one or other caregiver, you're going to become more dependent, and you're going to have less quality of life. So what are we looking at? There are some studies now that have said that shoulder pain is not as frequent in people who were childhood wheelchair users and then became adults. The theory there is that if you're a child wheelchair user, your shoulder joint has become more molded as you developed, and then you're less likely to have pain. Not sure if that's truly true or not, because we know that the child wheelchair user may have been, one, assisted a lot by parents, so they were pushed. They may not have done as much overhead activity as the adult did, or they may just not have come of age to have pain. And so again, we need to really look at those studies, because time will tell us whether the child will develop as much pain as the adult did, because there were very few children in those studies. So again, as we have more children with cerebral palsy, spina bifida, and other related disabilities such as traumatic brain injury, we will have to study to see if they actually develop shoulder pain as the adults have developed. So what is giving the wheelchair user pain? What it probably is the rotator cuff. We have a group of muscles that form what's called the rotator cuff over the shoulder, and as the adult wheelchair user uses the shoulder throughout the day, not just propelling the wheelchair but doing transfers and reaching up over the head, they can injure the muscles over the rotator cuff. Also, there's a bicep tendon. The muscle here is your bicep, and it inserts up in this area. You can get a tendinopathy, meaning the tendon can get injured, and you can get some tears, and that can cause you pain. That can be very discomforting, and it can interfere again with your overhead reaching, you're using the wheelchair, and then doing transfers. Conservative treatment is the most recommended activity for that, but you have to do relative rest. Well, it's difficult to do relative rest if you are working, if you have children, if you need to do a variety of activities, but that's the first thing that we ask you to do. And if you have a caregiver or a spouse or somebody that can help you, that would be good for you to do. If you can use a power chair or other means of transportation, that would be good. But again, if you're a single individual, or again you have a family, that can be difficult. Motrin, which is ibuprofen or naproxen or Aleve, has been helpful. Sometimes we can do cortisone injections into the bicipital tendon area here, or into the rotator cuff area, depending on which muscles is inflamed, generally the supraspinatus. PT has been very helpful. If you can find a very good physical therapist, they can do heat, ultrasound, or other techniques. And they can show you exercises which can be very helpful, such as a scapular exercise program to try to help with the muscles in that area. But again, trying a conservative approach can be very helpful. The other thing that can be helpful is if we have a therapist who can look at how the person is propelling the wheelchair. There are actually 4 different ways to propel a manual chair, and if they can look at the technique to which you're propelling the chair, they may be able to help retrain how to propel the chair so you're using a better technique. And when we're training children to propel a chair, it would be good if we can teach them the proper wheelchair propulsion, because there are some that propel in a very short, choppy way versus a longer stroke. And if we could work on better body mechanics in propelling the chair and a smoother stroke, it might help to save the joint. Also, there are push room activated power chairs and other things that we can do to try to help with the shoulder joint, and then looking at other transfer techniques that might help. The other is carpal tunnel syndrome. I think that a lot of people may be familiar with that, but the carpal tunnel in your wrist, you have an area under your wrist here where the median nerve goes under, and the median nerve supplies this aspect of your hand from here over. It usually presents with numbness in the 2 fingers here, and the wrist pain generally is worse when you're sleeping at night. So when you sleep at night, you may wake up with your hand feeling numbness or tingly, or it's clumsy. And unfortunately, it's generally both hands. So at night, you may wake up and, again, these fingers here are tingling and they're numb. And that is generally seen in individuals who are using loft-strand crutches, because when you're using your crutch, you're bearing weight through your hand. But it could also be seen in wheelchair users because, again, you're propelling the chair with your hands. And so, again, you're putting a lot of pressure through this area here. And it's a nerve entrapment because the nerve is getting entrapped through the tunnel under your hand here. The treatment, again, for this is rest. We want you to rest your wrist, but that can be difficult if you're using crutches, or again, if you're using a manual wheelchair as your way to get around. So we have to modify things. We might use a splint to splint this area into a better position. We can try oral steroids to try to reduce the inflammation, and then we can do a steroid block into the area. In more severe cases, we could do a surgical option where we do surgery to try to open this area here and to decompress it. The other thing is, we're back to the previous statement of weight control. If we have an individual whose body weight increases, that can worsen the median nerve function and can be problematic and cause more risk to carpal tunnel syndrome. Another thing that we can see is a Charcot arthropathy, and this is where you have a joint that doesn't have good sensation, and since you don't have good sensation, it can get traumatized as you're getting older and you're growing. It's usually seen in about 1 in 100 cases of spina bifida, and the median age of seeing it is 15 years 7 months, generally in the teenage years. So as the child is growing into adolescence, we see the joint get to be painful because they generally don't have sensation in that joint, but it can become a painful joint because of the deep area. But the foot and ankle is the most common, followed by the hip and knee. And what happens is that you have a rigid deformity of the foot. A lot of kids with spina bifida, again, are born with a club foot that may not be fully corrected, or just because of the way they're walking, because of the rigidity, it may become problematic. So the foot may be in poor alignment. They may, again, have had an ankle foot orthodesis when they were little, meaning the foot was and the ankle was surgically corrected, and it's a problematic joint. But as the teenager is walking, they don't have sensation there as far as the foot where it's being planted when they're walking, and they develop a significant ulceration there or significant deformity, and it becomes a significant problem. We can try different bracing. We can try starting just with an AFO. We can go above the knee, so it's a knee ankle foot orthosis. We can go up to the hip, or we can try a brace called the patella tendon bearing AFO. And again, this can be quite problematic. One of the last ones I just saw in clinic, the teenager had the area was completely healed, and he went to a party with his friends. They did a pool party, and he didn't tell his dad, and then he came back in the clinic because Dad noticed there was some blood on the carpet when he came home. And so both feet, when I looked at it under the surface of the foot, if this is his foot, there was a huge opening on the plantar surface of the foot, about this big on both of them. And he had it all healed, and they wanted to go to Florida about a month after I had seen him. And Dad said, all he did was go to overnight with his friends. And I said, well, that's about as much as it takes to open up. So again, he couldn't feel the defect, but again, it only took an overnight party with his friends at a pool. Knee deformities can occur if you don't have good hip abductors and your calf muscles aren't strong. Then you can get, the knees are problematic, and the knees can knock together, and then you get a rotatory. So the knees are rotating in, and you get abnormal stresses on the knees, and you can get degenerative changes. So again, as you're going from the small child to a more teenage child to a young adult, again, you can be walking with your knees knocking in, and that can cause a lot of arthritis and deformity. The same thing with the hips. If you have an adult with a high sacral spina bifida, meaning that the ankles are involved. So again, it's just an S1 level where you have strength at the hips, you have strength at the knees, but your feet aren't well integrated. You can get increased knee extension. So when you're standing, your knees are locking back, and you can get degenerative changes at the knees and the hips. So again, a lot of deformity and a lot of pain can develop at the hips and knees depending on your level, and it's just from the increasing repetitive deformities from walking. So again, just the stress as you get older and you get taller, you can develop arthritis both in your hips and your knees. So again, we're seeing early arthritis developing. Hip flexion contractures, I think a lot of us know that if you have a lumbar level spina bifida, or meaning that your hips are weak and you have strength in your hips and your knees, but you start getting flexion contractures, what's going to happen as you stand, I'm going to step away for a second. You may be standing like this. And so as you flex forward, your back is going to get curved, and that's going to put pressure on you to develop back pain. So not everything that's a tethered cord can give you back pain. If you're getting hip flexion contractures, your back may get lordotic, and then you're going to get pain. If you develop increased weight gain, you're going to also get more back pain. And so again, that's going to give you pain as you get older. So not everything is a tethered cord. You may get back pain just from the way you're standing. So again, here's kind of, so we're talking about when you present for back pain as a young adult or an adult, it could be a tethered cord, but it could also just be from deconditioning. As we get to be young adults and adults, we don't always exercise. So as we're not exercising anymore, we get deconditioned, and then we develop back pain. Also, as we become adults, some develop this little front projection that is called excessive weight. And so you get this little projection on your belly, and men generally have a little more than females. But if you have a projection here on your tummy, that can then be excessive weight that gives you more back discomfort. And so you're lordotic because your hip flexion contracture, and you're getting back pain. Also, again, the degenerative arthritis that adults get. Again, if you're having weakness in your legs, you can get arthritis at your hips and at your knees and at your ankles, and that can lead to pain. Low back pain may be due to, again, just chronic lower extremity weakness. If you're walking with an abnormal gait and pelvic obliquity because your hips are uneven, you can get excessive lordosis again, and that can give you back pain. So it's really good to make sure if you're having difficulties, I think an adult physiatrist would be a good one to see, because they can help try to differentiate why that pain is and try to tease that out, and they could really help you develop an exercise program either with an adult physical therapist and come up with some suggestions. You might benefit from Motrin or Aleve, and again, a stepwise progression of nonsteroidal anti-inflammatory medications. That's what Motrin and Aleve is, might be very helpful. Physical therapy can be very beneficial in trying to help with the pain. Try to get you in a strengthening program, good with a physical therapist, and sometimes Neurontin or Lyrica can be helpful. So not every back pain is a tethered cord, and again, if we can get you back on an exercise program, get you back walking properly, relook at your braces, and then get you in a good strengthening program, that can be very helpful. Osteoporosis can be very problematic. About 50% of adults with spina bifida have osteoporosis, and this is usually multifactorial. Just being a female can lead to osteoporosis. Renal failure can lead to osteoporosis. If you've had an ileal diversion, reduced physical activity, if you're not active, you can get osteoporosis. Any epilepsy can be problematic depending on what medications you're on for your epilepsy can lead to osteoporosis. Oral corticosteroids for a variety of reasons, and then family history can be problematic. We look at the lumbar spine, femoral neck, and the femoral trochanter. The problem is we don't want you to rush out and all of a sudden start taking a lot of calcium till we know your history, because too much calcium can be problematic to your potential for forming stones. So it's good to talk to your physician about how much calcium do you need, because again, your history of whether you've had kidney stones or not are going to be important. But again, about 50% are at risk for osteoporosis or have osteoporosis. The yearly incidence of fracture in individuals with spina bifida, in adolescents it's 29 per 1,000, and then in adults it's 18 per 1,000. Most are going to involve the femur and the tibia. Generally seen more in the non-ambulatory than the ambulatory, but can be seen in the ambulatory individual. And so again, we really want to look at what your risk is, and calcium and vitamin D supplements may be beneficial, but we have to look at, again, are the individuals having troubles with gastroesophageal reflux? Do you already have problems with heartburn? Is that going to be problematic depending on what we put you on? Is constipation a problem? So too much calcium may be problematic for your stool program. And then again, are you already having kidney stones? So we have to balance all of that. Exercise and fitness is really important, and this is what I talk to a lot of the teens and young adults. I do a young adult and teen clinic called Kayak, and we really talk to the teens about we have to develop a lifelong fitness program. Same thing with the adults. It's recommended that everybody exercise 30 minutes 3 times per week. I don't think any adults generally get that in unless you are really striving for your fitness. But this is what everybody should be working for, because it's going to help in the long run. We in America don't exercise enough. So the research with spinal cord injury and those who exercise, this is what it's showing. If you exercise 3 times per week for 30 minutes, there's an increase in strength and power. So your overall strength and power for doing your transfers, for your ambulation, and for your daily activities will increase. You have an increase in physical work capacity. So your physical work ability is improved. You have a higher level of high-density lipoprotein than your sedentary peers. So that's your good proteins. You have an increased quality of life score. So your quality of life and what you perceive life is higher. You have an increased ability of performing daily activities. So again, your ADLs are better. And then employment, interestingly enough, was positively related. Your cardiovascular disease may be reduced by aerobic fitness. And aerobic fitness is not just physical activity. This is exercising and increasing your oxygen capacity while you're exercising. So those who increase their aerobic fitness training may lower their cardiovascular disease. Aerobic fitness training may lead to a 10 to 20% increase in peak oxygen uptake. So if you could exercise to the point where you're increasing your oxygen uptake, it showed a positive effect on your reduction of cardiovascular disease. So they found that if you increased it by 220 mils increase in peak oxygen uptake, then you would individuals with spina bifida they felt would be 1.8 times more likely to have no cardiovascular disease. So again, this would be positive if we could get everybody to exercise, because that would reduce your cardiovascular disease risk. And then aerobic fitness, again, is more than physical activity. And this is a positive thing that we have to get people to see. A lot of people feel they're exercising, but they're really not exercising to the point of increasing your heart rate or increasing your oxygen capacity. So that's frequently what I talk to the teenagers and young adults. They may say, well, I'm exercising. I shoot basketballs with my siblings, or I shoot basketballs with the guys. But we really got to get you out there and exercise. And you need to do some swimming. People need to, really go out there and ride around the track in their chairs, or they need to go out there and do something where they actually increase their heart rate. As I say, you got to sweat when you're doing it. You got to really physically do something. So this is where I said we were going to come back to the U.S. leading causes of death. So we can talk about the preventive health. We're talking about disease to the heart, neoplasms, diabetes, kidney, and essential hypertension. Not that we're focusing per se on that, but we're going to talk about what we need to do for our preventive health. Heart disease is something that really is out there, and if we're going to try to do something preventive for ourselves, again, we need to optimize our life fitness plan. As I said, we have to have something out there where you're aerobically doing things to increase your physical endurance. Healthy diet is so important. I think we in the United States, we have so much access to food that we really don't focus on what's a healthy diet. So we really need to focus on eating healthy and keeping ourselves on an ideal body weight. And we have to really work with your physician on what is your ideal body weight. Individuals, as you know, with spina bifida, some people have a shorter trunk and they have shorter legs. And so we have to say, well, what is your ideal body weight? Others have a nice high height, and so they may have a different body weight. But we really have to understand what body weight is for that individual and come up with what is your ideal body weight, and then set your healthy diet to maintain an ideal body weight. Good sleeping habits. We have to really hone in on sleeping habits. So many people in the U.S. think that, oh, I only need about 6 hours of sleep, and we push that limit, particularly as young adults. We really need to get good sleeping habits, and then if you have sleep apnea, we really need to treat it. I can't tell you how many individuals that I know, they have sleep apnea, they have a nice CPAP machine, or they have a nice BiPAP machine, and where is it? It's in the closet. Because they don't have a mouthpiece or a nose piece that fits well, and they're afraid to come back and get another one. Make sure it fits well, because if it's sitting in the closet, it's doing you no good. You got to use it. And so if you don't have a nice piece that's fitting well, come back and make sure you get one, because there's lots of them. And you got to get the one that fits you, and it's got to fit well. Then there's high blood pressure. I can't tell you how many people think that high blood pressure is just due to a familiar thing. And if you're seeing your family practice doctor and he's not familiar with spina bifida, we need to make sure that high blood pressure is monitored right. And high blood pressure is really an insight to your kidneys, not just your heart. And so if you have high blood pressure, we really need to be looking at your kidneys to make sure, is it due to your kidneys or is it due to your heart? Because if you have spina bifida, we want to look at your kidneys and make sure that your kidneys aren't showing you that you have high blood pressure, because your high blood pressure may be more from your kidneys than it is your heart. And we have to think of yourself globally. And a lot of people, if you don't have spina bifida, they're going to say high blood pressure is due to your heart. But for individuals with spina bifida, we need to make sure your kidneys are functioning well. Next thing is malignant neoplasms. This is something in the whole disability arena that usually gets overlooked, because how could you have two disabilities? When we're talking about individuals with disabilities, it is so easy to overlook, because nobody could have two disabilities, could they? And we have to make sure that we really look at general health. The cancer rate in individuals with disabilities is skyrocketing because nobody looks to say that you could have two disabilities. So in cancer health issues, we really at age 50 need to be looking at your whole health. And actually we need to go before that when we're looking at colon cancer and bladder cancer. We need to make sure that bladder cancer is being screened if you've ever had a diversion, if you have a urostomy, you had an ileoconduit. or anything that's diverted your bladder. And then colon cancer, again, at age 50 or sooner, if you're having any bleeding needs to be done, or if you've had any diversions, your cancer needs to be monitored closely. Under women's health issue, women are just as likely as anybody else to have a breast cancer, and I talk to all the girls in clinic. You need to be doing your own breast exams, and you need to be taught how to do that. If there's a cognitive impairment and the young ladies are living in a group home, then somebody at the group home needs to be monitoring this for them, and somebody that's comfortable. If there's nobody that's comfortable doing that, then mom or a sister needs to come in and be monitoring. Breast exams need to be started as early as 20, 21 years of age. My youngest friend that had breast cancer was age 25, 26 when she presented. But we need not ignore our young ladies. All young ladies need to be have monthly breast exams. And then uterine cancer also needs to be monitored. It's so easy to forget that every woman needs to be monitored for uterine cancer, and pap smears need to be done. And so we don't want to miss this on all women. And so all women, regardless of your disability, need to be screened, and you need to make sure that you have either your family practice physician or your obstetrician needs to be comfortable in helping you to do this. And then on men's health, testicular cancer needs to be monitored, and the same thing with prostate cancer. We need not to forget that you're also a man, and these cancers do not disappear just because you have a primary disability. The other one is diabetes. Diabetes is on the rise in our United States and other developed countries because of the increased access to, again, our diets and our increased weight. And so we need to keep in mind that you need to have screening if your weight is excessive, and even if your weight is not excessive, you need to keep in mind that diabetes needs to be screened periodically if you're having any symptoms, or if your weight is increased, you need to have your general health screened, and the same thing with high cholesterol. These are things that, again, need to be monitored, and if there's high cholesterol screenings being done, don't be shy. Go ahead and have screening, and with your general health screening, your physician should be screening this as you're getting older. And then again, ideal diet and health lifestyle needs to be part of the preteen through adolescent and young adult years to lay the foundation for good health. It's so easy for us to use food as a bribe when children are younger, but we shouldn't do that. We only need a certain amount of calories in our life, and it's so easy here to double, get a Big Mac and just order the fries and the soda to go with it. I think McDonald's sweet tea is the best thing that came along, but if you looked and see how much calories a sweet tea has, you'd be amazed. And the same thing with a lot of our coffees, they all have a lot of calories, so we have to balance our diet so that we don't end up to be all too heavy. And so again, ideal diet starts young, and we have to balance it so we don't end up excessively heavy. Again, the other key thing is our kidneys, and in Spina Bifida, we really need to look at the kidneys. I think you need an annual renal ultrasound to examine for optimal health. Blood pressure, again, I think I've said that a couple of times. Blood pressure is not just due to cardiac. You need to monitor your blood pressure for your renal health. It's going to show you if your renal health is becoming problematic. You need to have a yearly exams for monitoring bladder function and cathing. It's so important. This is what made the difference in survival for individuals between the 60s and 70s to now for long-term outcome. And again, this is my last slide. I believe that our background and our circumstances may have influenced who we are, but we are responsible for who we become and where we go. Life has changed. Again, in the 60s and 70s was when things began to change for those who had disabilities, and it is now that we have the future ahead of us. Individuals with disabilities should now survive into their 65 to 70 years, and we should all make it to then. I'm planning on being 100. And I hope you all will join me in that goal for yourselves. Any questions?
Talking about the knees and the deformities, and you said that how the knees can be somewhat deformed. Now, he used to walk early, and now he's in a chair, but he's also still having knee problems. Can you figure out, why? Or is it because when he was younger, when he walked, And his hips are both out.
The knee, yeah, I got
understand
you.
that?
You said that as he was younger, he walked, and now that he's an adult, he's in a chair, and his knees are still giving him pain.
Yes.
Correct. And again, some of us, or some individuals can develop acquired arthritis young, and it can still be problematic with his transfers and as we age because the arthritis is still there. Go ahead.
Hold on a minute. I got it right here. What about when you said the prevention of cancer?
Yes.
And you said it with bladder cancer, and you said everything. But what about an augmentation, a bladder that's been augmented? Can they also get cancer? Because you said when you said other things can give you the cancer.
In the augmentation, I think you still have to be screened because you've augmented that bladder.
Okay.
Mm-hmm.
I had a question about DEXA scans. My doctor ordered one, but they ended up doing a scan of my arm, my non-dominant arm, they said. So I do a lot of physical activity, so I feel like my upper body is really strong, but I don't know what that would mean for my lower body.
It's difficult to know where to do a DEXA scan because in individuals with spina bifida, if the hips are dislocated, it may not be a true area. If your back has had surgery, then you're not a true area. And if your ankles have had surgery, it's not a true area. So that's the problematic place of where should we do a DEXA scan.
All over your body, so I'm not sure what just doing my arm would actually say.
It's a difficult thing because we don't know exactly where, but if we monitor you as you get older in the same spot, then we have a focal point to follow. Any other questions? Well, thank you for coming. Oh, we got one more. Sorry.
I was just going to ask, what is I might be mispronouncing this, the Charcot arthropathy?
It's a joint that doesn't have sensation that has acquired difficulties. So you can get deformity there and increasing difficulty.
Real quickly, if there's anybody who did not get a handout, we do have a couple more now. If you want to see me for a handout, I've got some more. Thank you.
Thank you for attending this session. Because meeting your needs is important to us, we need your feedback on this presentation. Please take a few moments to complete our evaluation, which can be located by clicking on the Clicking Here hyperlink on your screen. It will only take a few clicks of your mouse to provide us information to make the SBU experience better for you and others. If you have any questions relating to SBU, please contact us at sbu@sbaa.org.